morning. We're thrilled to welcome you to our exciting new series, Moving Forward, Cognition and Cognitive Challenges in Parkinson's Disease. This series is brought to you by Parkinson's Community Los Angeles, featuring insights from 3 speech pathologists. Today we'll be hearing from Sofia Rogers. I'm Suzanne Johnson, a PCLA advocate. For those who don't know us, we are a nonprofit that supports families living with Parkinson's disease through our free education programs like this one, online and in-person support groups, social events, and more. Today's conversation is made possible by important donations from people just like you in the Parkinson's community. If you appreciate our work, please consider making a donation at pcla.org. Your donation is 100% tax deductible, so thank you in advance. We rely on your generosity to help us continue this important work. A little bit about our presenter. Sofia Rogers holds a Master's of Art degree in speech language pathology from Cal State University, Los Angeles. She serves as a clinical educator at CSULA, where she works primarily with Spanish-speaking adults with aphasia and facilitates a student group that provides speak out therapy services for adults with Parkinson's disease. She also practices as a speech language pathologist in both acute care and acute rehabilitation settings. Sophia specializes in delivering rehabilitative speech therapy services to inpatients within acute care and acute rehab environments. So let's get started, Sophia.
Good morning. It's good to be here. I'm going to go ahead and share my slides. I'll go through the slides, then we can have questions at the end. Okay, so as you heard, I am a speech pathologist at Cal State LA. I work in, sorry, let me start. I'm a speech language pathologist. I work in acute rehab and at Cal State LA. Working with people who've had strokes, who have Parkinson's, and I facilitate a student-led group of speak out therapy. So today we're going to talk about swallowing difficulties in Parkinson's, and that is dysphagia. So when we talk about dysphagia, we're talking about swallowing difficulties. It's the medical term that means, again, swallowing difficulties. It can mean that food or liquid takes more time and effort to move from your stomach to your mouth. It's difficulty swallowing. It can affect any stage of the swallowing process. And there are 3 stages of swallowing, which is a pretty complex process that involves over 50 muscles, multiple nerves to coordinate this process. So when any part of those phases are affected, dysphagia can occur. It can involve liquids, solids, or both, and it ranges from mild to severe safety concerns, and it requires evaluation and treatment from a speech language pathologist. I'm going to show you a normal swallow that's on the left and an abnormal swallow on the right. You're going to notice some black liquid, and that's the food bolus. This is from a video swallow. So let's take a look. Oh. So there's the bolus. It goes down nice and clean in a normal swallow. And then in an abnormal swallow, you can see the bolus is just discoordinated. Some enters the airway, actually quite a bit. So that's an abnormal swallow, just so that you have an idea. So the first thing I want to say is that dysphagia does not mean that you're aspirating, that it's going down the wrong way. Dysphagia can happen at different phases, and that's what we're going to talk about. So dysphagia can affect up to 80% of people with Parkinson's at some point in their journey. So because Parkinson's is a neurological disease that affects the muscles, that means it can affect the muscles of swallowing. So it can affect the muscle control, the movement and coordination of the mouth, tongue, throat and esophagus. So because it affects the muscles, we have reduced control, muscle control in the throat and the esophagus. We can have a delayed swallow reflex, decreased saliva management, and changes in tongue movement. The good news is that early recognition and proactive management can make a significant difference in maintaining your quality of life and nutrition. So I'm going to take you through the 3 phases of swallowing. First, I want you to look at this graphic. We have our lips here, our teeth, our tongue, which is actually a huge multiple of muscles, but we only see this top part of it. We have the back of the throat. We have the epiglottis, which is a little flap that protects the airway as we swallow. This is the airway, and then right behind that is the esophagus. So that's where we want to see the food to go down. If you're eating, so the first phase of eating is the oral phase, and it's a voluntary phase. So we chew our food, our tongue moves it from side to side, the saliva moistens it, it creates a little ball, and then the tongue pushes it back. Okay, so that's voluntary. So okay, so you chew your food, you mix it with saliva, the tongue pushes it back into your mouth. The Parkinson's impact, because you have reduced muscle weakness, reduced tongue movement, it has trouble moving food from side to side, it has trouble forming the little bolus and pushing the food back. So that can result in food pocketing in the cheeks, right? It can leave residue on the tongue. So those are the impacts that Parkinson's has on that oral phase. The next phase is going to be the pharyngeal phase, and that's an automatic phase. That happens at the back of the throat. Once the food hits the back of the throat, the body triggers a swallow and pushes the food down. The trachea elevates, moves forward, the epiglottis flaps down, and the food passes. Okay, so that's the pharyngeal. It's automatic. So again, your swallow triggers by reflex. Your airway is protected, protecting your lungs. The food moves down your throat. The Parkinson's impact, again, if you may have a delayed swallow reflex, you may have muscle weakness that doesn't completely close the airway, and that can result in food residue in the throat if the muscles aren't working. So you can have some food residue in the throat, possibly can fall into the airway, not necessarily. And then the last phase is the esophageal phase. That's down into the esophagus, down front of your chest into your stomach. These are muscle contractions that push the food down into your stomach. It's like kind of like a snake. It constricts it, pushes it, constricts it, and pushes it down into the stomach. Okay, so it travels down through muscle contractions. And the Parkinson's impact is that if you have muscle weakness, muscle slowness, it's going to take a longer time for those muscles to push the food down into the esophagus. You may feel like food sticking in your chest area. So that's the impact, right? That's how Parkinson's, again, slower muscles, coordination is impacted. What are the signs to look for if you have some dysphagia? You might be coughing or choking with liquids or solids. Could be both, could be either. You might feel food stuck in your throat, right? Like you swallow and it's just kind of not going down. It might take you a longer time to maybe finish some meals. You might have some discoordination. Chewing might be difficult. Again, that tongue movement, pushing the food back, it just might take longer. So, taking longer time to finish meals. You might find that you're having difficulty managing your saliva. That could be you have reduced lip closure, like your muscles aren't closing your mouth all the way. You have reduced sensation where your body isn't sensing the saliva, so you're not triggering a swallow. That could be a sign of dysphagia. Having a wet or gurgly voice after you've eaten or had something to drink could mean that your airway isn't fully closed when you swallow the food. So some of it can be sitting on your vocal cords, causing that gurgly voice. Maybe you have some unintended weight loss because meals take longer or you're not eating as much, right? That can be a sign of dysphagia. Avoiding certain foods or textures. Maybe you don't eat something because you feel scared, because you know that it might cause you to cough or choke, right? So that can be a sign. It's like, no, I can't eat those crackers because it just, I cough all the time. That can be a sign of dysphagia. And then if you have recurrent pneumonia, that can be a sign that you are maybe aspirating some food and it is causing a pneumonia. Saying that, just because you're aspirating doesn't mean it's causing pneumonia every time, and we'll talk about that. So if you're showing any of these signs, what are you going to do? You're going to talk to your doctor. You're going to request a swallow evaluation from a speech-language pathologist. If you are at the hospital for whatever reason, I would request to see an SLP, a speech pathologist, to evaluate your swallowing. Okay, so then we're going to do this is the clinical swallow evaluation. This is the hospital SLP toolkit. If you've ever had a swallow evaluation at the hospital, the SLP will walk in with some water, applesauce, and a cracker. Never fails. So generally when you have a clinical swallow evaluation, we're going to first do an oral mech exam. We're going to check out your structures of your mouth. We're going to have you open your mouth. We're going to have you stick out your tongue, move it from side to side, point it up, point it down. What we're looking for is your range of motion. We're looking to see, can you lateralize your tongue, right? Can you move your tongue? Can you open your mouth wide? As you recall, the oral phase requires that tongue movement. And so we're looking to see, we've done a chart review. We know you have Parkinson's. So those are the kinds of things that we're looking for. And so with these items, we try to simulate an entire meal with different textures. We want to see, with how you do with water. Generally, water moves a lot faster, and so the body needs to work quicker to protect the airway. So we'll try some water. We can try some ice chips. We'll try some applesauce. We're going to look to see, after you swallow, do you have leftover residue? Is there applesauce in your cheeks? Is it left over on your tongue? That's going to be telling for us that maybe you do have some of that oral dysphagia. And then we're going to do a cracker. We want to see how you're chewing. Are you lateralizing your jaw? Like, are you moving your jaw from side to side when you chew? Is it taking multiple swallows to get the graham cracker back, right? That can be that pharyngeal phase. And then we're going to look for that residue. Do you have any in your cheeks where maybe your tongue is too weak? You can't do what we call a lingual sweep, like get your tongue in there to push it out. Do you have a lot of residue on your tongue? Are you requiring water to push that back, right? So we're looking at all these things when we're doing a video swallow, seeing if we notice signs of dysphagia. I generally, when someone comes into the hospital and they have Parkinson's and they are showing some signs of dysphagia, I will recommend a video swallow, not because I think that they're aspirating, but just to kind of get a baseline, because we know that Parkinson's can have dysphagia. Over 80% can have dysphagia. And so I want to get a baseline for this patient, and we can kind of keep an eye on them to see if their swallow progresses in subsequent visits. So that's one assessment. And then we have two gold standard instrumental studies. These are, we have the FEES and we have the video swallow. So if we've determined that you need these, maybe you're showing signs of aspiration, or like I said, you have Parkinson's and maybe you are having those dysphagia symptoms, we're going to do an instrumental again to get a baseline. I am not FEES trained, so my knowledge is limited in this, but basically it's a camera that goes up your nose, down into your throat, and the clinician can visualize the airway, your vocal cords, the esophagus. They feed you during this test, and they can see the results after your swallow. Is there residue in the airway? Did it clear completely, right? And so we're looking at that pharyngeal phase. We have a saying as speech pathologists that we can't treat what we can't see. So giving these instrumental tests gives us an idea of where there might be an impairment. So the next one is a video swallow, and I actually am trained to do these, and I perform them regularly. So this is, you're taken down to radiology, and you're given different consistencies of barium. So it's a white contrast, but it shows up black on the screen, like the video that I showed you with the normal and abnormal swallow. So I'm going to give you something that's like the consistency of water, something that's the consistency of syrup that you would put on pancakes, a honey consistency, and then a pudding, and then a pudding with cracker. And so what we do is we give you these different consistencies and we watch it go down. So this is kind of the view I have minus the labels, that's for you. But I watch the food bolus go down like in that video. I'm looking to see if there's difficulty pushing the food back with the tongue, right? That can give me information about oral dysphagia. I'm looking to see if there's residue after the swallow, right? It's going to show up as black. Then I know there's something going on in that pharyngeal phase. If there's anything that enters the airway, I can see if someone aspirates. And then in the esophagus, again, I can see if it's kind of staying there for a long time before it moves down. So this is the only true way to see if someone's aspirating are these gold standard tests. And so, again, we can't treat what we can't see. We use this to base our diagnosis and our interventions, our treatments. So another thing that you can do to get assessed, maybe your nutrition, you don't feel like it's great, so you can seek a nutritional advice from a registered dietitian or a nutritionist to make sure that you're meeting your nutritional needs. There are questionnaires. So you may have seen this questionnaire, the EAT 10. And this is a questionnaire that if you'd like, we can do it right now in person. You guys can see how you do. Basically, a score of 3 or above may indicate some dysphagia. Again, doesn't mean you're aspirating if you have dysphagia. And then a score of 16 does indicate a higher risk of aspiration, right? So again, we just to be careful. But if you'd like, we can go through this right now since it's here. It's 10 questions. The 0 is no problem, and then 4 is a severe problem, and then we have a 1, 2, and 3 in between. So see, I'll just kind of go through it. You will get a copy of my slides after this, so if you want to do it on your own at home, that's fine too. So my swallowing problem has caused me to lose weight. 0, no problem. A 4, severe, or maybe you're somewhere in between. The second question, my swallowing problem interferes with my ability to go out for meals. 0, no problem. 4, severe, or somewhere in between. Number 3, swallowing liquids takes time. Swallowing liquids takes effort. So maybe it's hard for you to swallow liquids, or maybe it's not. So 0 to 4. The next question, number 4, swallowing solids takes effort. 0 is no problem. 4 is severe, and then 1, 2, or 3 in between. 5, swallowing pills takes extra effort. Again, on a scale from 0 to 4, 4 being most severe, 0, no problem. Number 6, swallowing is painful. Go ahead and rate yourself from 0 to 4. 7, the pleasure of eating is affected by my swallowing. You can rate yourself from 0 to 4. Number 8, when I swallow, food sticks in my throat. 0 is no problem. 4 would be a severe problem, or somewhere in between. Number 9, I cough when I eat. 0 is no problem, and then 4, a severe problem. And the last one, swallowing is stressful. So 0 is no problem, and then we have 4 is a severe problem, or somewhere in between. So you can total that up. A score of 3 or above may indicate dysphagia. A score of 16 and above indicates a higher risk of aspiration. And this is a good thing. If you do score a 3 or above, this is something you can take to your doctor and say, I took this questionnaire, I feel like I have some dysphagia signs, please refer me to a speech pathologist. And there are ways to manage it. And we're going to get into that. So again, these were the different assessments and diagnoses tools: the clinical swallow evaluation, the 2 gold standards instrumentals, the FEES, and the modified barium swallow, a nutritional assessment, and questionnaires. So based on your evaluation, it may be recommended that your diet is modified. So there's different textures that might be recommended. It might be soft and bite-sized. Maybe a bite-sized type of food is easier for you to manage. There's minced and moist, which is basically diced food, and that is so that you don't have to chew as much. It's almost ready to swallow. So you just don't have to chew because it's diced. Then there's puree textures, and that's for someone who has, more severe dysphagia. Liquids may be modified, though I would ask for a video swallow prior to any liquid modification. And then as speech therapists, we're always going to recommend the safest and least restrictive diet for you. So here are just some modifications that might, help you. You can add sauces to your foods, eating flaky fish, some ground meat, cooking your vegetables till they're, tender so you don't have to, they're not too fibrous, eating some softer fruits. Foods to approach with caution, those dry, crumbly kind of crackers, dry bread that might get stuck. Mixed consistencies, those are things like cereal, soup with chunks. Sometimes the body has a hard time coordinating, holding on to a solid and swallowing the liquid with those mixed consistencies. Sticky foods, peanut butter, white bread, caramels, those are all, with a normal swallower, sometimes very sticky. So if you have reduced muscle weakness and coordination, then that might be even harder. And then, those raw vegetables might be too hard, tough meats. So a speech language pathologist can provide you with, some recommendations based on your needs, based on an evaluation. Now, there's also the medication, right? A lot of times timing of medication can help. So swallowing might be better during your on time with your medication. Schedule your meals when your medication is most effective, when you're at that peak, right? Coordinate with your neurologist for the timing of when to take your medication with your meals, or, to coordinate with your meals. And note that some medications may worsen dysphagia. Anticholinergics. I meant to look that up to make sure I was saying it properly. I'm not sure. But they're used to treat conditions like asthma or overactive bladder. So if you take that, it might be contributing to some dysphagia. And then, of course, never stop taking medications without consulting your doctor. What if you're having trouble swallowing pills, right? That might be an issue too. So a lot of times we recommend putting pills in like a pudding. Ice cream is very popular. Applesauce, something, where you can just put your pill in, something to make it slippery. Try taking one pill at a time. Take smaller pills first. There are some products that help you that are made for medications to make them slippery. Slippery. So it's called Gloop, and it's like a coating that one pump coats the pill, and then you swallow it. I think it comes in vanilla and raspberry. And then there's this other thing called Pill Glide, where you spray it on the pill, and it's supposed to coat it and make it more slippery and easier to swallow. So things that you can look into. Okay, so now here are some things you can do to help you to be proactive in keeping your dysphagia at bay, or keep it, maintain the level that you have. So there's LSVT, Lee Silverman voice treatment. I'm not trained in that, but it's an intensive speech therapy program that focuses on increasing vocal loudness. There is evidence that it improves not only your voice, but also the swallowing function. It helps to strengthen your respiratory and laryngeal muscles. There's Speak Out Therapy, in which I am trained, and that's a program that uses intent. It has a cognitive component to it, some sustained phonation exercises, and research shows that it has improvements in voice, speech intelligibility, and swallowing outcomes. It focuses on speaking with intent and effort. And there's singing therapy too, right? There's a lot of evidence now that shows those glides that you do, like any kind of scale, musical scales that you do, elevates that larynx and works on those vocal cords. So that also has evidence behind it to help strengthen those muscles in your throat. And then expiratory muscle strength training. This has a lot of evidence to help in strengthening that swallow function. So this is a little tool. It's called the EMST, and it's a tool that has a dial, and you blow against resistance. And so this is something that you would, talk with your speech therapist about to get trained on it. There's a whole protocol on how to do it. But this can improve your swallowing, and very importantly, it can improve your cough. Having a good, strong cough can help with anything, expelling material that may be falling into your lungs, right? So retaining a good, strong cough is very key in this whole process. So an EMST tool can help. And so I would ask your speech pathologist to, I think you have to buy it. It's I think like $60. It's like a 5-week program. I think it's 25 repetitions per day, 5 days a week for 4 to 5 weeks. And you can increase or decrease the amount of resistance. And a speech therapist can help you find that good spot where it's not too easy and not too hard, and it's actually going to make a difference. A lot of research around this, a lot about cough strength. So there are also some other strategies you can use. There's an effortful swallow. So that's when you pretend you're swallowing a golf ball and swallow hard. If you want to try it right now, pretend that you're swallowing a golf ball and just squeeze it all the way down and try to engage all those muscles. If you need to take a sip of water to help, which I think I will, you can do that. And just swallow really hard. So that's something you can do because it's engaging the muscles. It increases your tongue base retraction, which is something that helps clear that bolus from your throat, from the pharynx. You can try multiple swallows. So when you're eating, you can swallow your food and then try to swallow again before you put anything else in your mouth. Might take 2 times. You can combine it with an effortful swallow and see if that helps to clear what's in your throat. But as you're doing these, it's also strengthening those muscles, right? It's kind of like a little workout. So you're swallowing hard or you're multiple swallowing. It can help reduce the pharyngeal residue. These others require more professional instruction because there are some contraindications. If you have heart issues, maybe you don't want to do the supraglottic swallow, but this also helps to protect the airway. You basically hold your breath, swallow, and then cough immediately after. The Mendelssohn maneuver is a little bit harder. You have to hold up your larynx at the peak of swallow and then swallow. Again, that should be done with the help of an SLP. Here are other swallowing exercises. These can help maintain and improve your swallow function. Again, talk to an SLP. But doing tongue exercises, like pushing it up against the roof of your mouth, that can help strengthen the tongue. Doing those. It shouldn't cause any pain in your tongue. If it is, you're probably doing it wrong, but I would talk to an SLP. Jaw exercises, opening your jaw wide open and holding it for a count of 5 or 10 can help with laryngeal elevation and also with that range of motion, right? A lot of times when we have Parkinson's, you tend not to open your mouth wide, right? And so this can help you keep that range of motion for your jaw. And then there's voice exercises. If you're doing LSVT, if you're doing speak out, do them as prescribed, do them regularly. I know speak out, you need to do your exercises every day, right? And so keep doing those. All of that's going to contribute to you maintaining your swallow where it is and not having it worsen. So consistency is key. Daily practice yields best results. So I want to say again that just because you have dysphagia doesn't mean you're aspirating. And just because you're aspirating doesn't mean you're going to get pneumonia. I really want to emphasize that. So here is a list of things that are going to help you. So you're less likely to develop an aspiration pneumonia if you continue to independently feed yourself, you are independent for oral care, you maintain good oral care, very important. I mean, we've been taught since we were kids, you have to brush your teeth at least twice a day, right? It's even more important if you have Parkinson's. Again, that muscle weakness in your mouth can cause you to have residue. We want to make sure there's nothing left over. So good oral hygiene. Also, remaining ambulatory, physically active, that's also key. If you do your boxing, if you do yoga, right, keep up. If you take your walks, try to stay as physically active as possible. Having good respiratory status, that good cough function, right? Maintaining a good, effective cough can kick out anything that may have landed in your lungs, right? So that cough is so important. No history of aspiration pneumonia, having a good, healthy immune system, and not being a smoker. So you're less likely to develop an aspiration pneumonia if these are true for you. It doesn't have to be all, but a lot of those, right? So unfortunately, there will come a time, right, that you will have to consider alternative nutrition. Maybe you're not meeting your dietary needs, your nutritional needs, despite any of the modifications that you've done. If you do have a recurrent aspiration pneumonia, you're not meeting those hydration needs. It might be taking you longer to eat your meals, greater than 45 minutes, and you may require a feeding tube. But what I'm going to say is that is a very personal decision. That's between the patient and the family. I encourage you to, do your research and let your wishes be known before it's time. So talk to your doctors, do your research. A PEG tube can prolong your life, right? But again, personal decision. So that's what I will say about that. And along this whole journey, you need your support team, right? You need your neurologist who's going to manage your Parkinson's medication and your overall care, your SLP for your swallow evaluation, for any dysphagia therapy you may need, cognitive therapy, I'll throw that in there. Your occupational therapist, you might need some adaptive equipment. They're going to help you with that upper arm strength. A dietitian and nutritionist who can make sure that you're getting adequate nutrition. They can help you with meal planning. Your primary care doctor can coordinate hopefully everything. Hopefully you have a good one. And then support groups, right? Connect with others because you're not alone. And PCLA is a great, place to be. They have lots of support groups. So also, again, if you feel like you need a swallow evaluation, tell your doctor. Earlier intervention is going to lead to better outcomes. And let's see, we have some practical mealtime tips. Eat when you're well rested, minimize some distractions, sit upright for 30 minutes after eating, right? Again, that slowness in your esophagus might take it longer to get into your stomach, so that, stay sitting up for a while. If you need to use adaptive utensils, do so. Stay hydrated throughout the day. Consider smaller, more frequent meals. Allow extra time for meals. And for me, I always say safe swallow strategies are small bites, small sips at a slower rate, right? Those are things that I always tell my patients. Small bites and sips, and eat at a slower rate. So, it's all about maintaining your quality of life. Just because you have dysphagia, if you do, you can still go out to eat, right? Choose restaurants that have suitable menu options for the foods that you need to eat. If you need it modified, you want extra sauce, give me some ranch, some gravy, ask for it. Maybe eat before peak times to reduce stress so you don't feel like you need to rush because you feel like you're taking up a table, right? Those are some good things to do. Let your people that you're eating with know how they can support you. And then focus on conversation and connection, not just food, right? You can, in Spanish, there's a saying called sobremesa, and that's like talking once the meal is done, right? It's just focus on that, on the social part of it. It doesn't have to be about the food. So I know that changes in eating can be emotionally challenging, and it's normal to feel frustrated or sad. Just talk to your healthcare team, right? Remember, adapting doesn't mean giving up. It means moving forward strategically. And please know you're not alone in this journey. So here's some key takeaways. Swallowing changes are common, but they are manageable. Early recognition and intervention can make a difference. You can maintain your quality of life with the right approach. Talk to your healthcare team. If you need an evaluation, please request one. Try to implement 1 or 2 strategies this week. Stay proactive, stay positive, keep moving forward. You've got this. My goal for you is that you maintain a good quality of life. I want you to be able to enjoy your favorite foods for as long as possible. Although they may look a little different, right? You might have to have it in a different format. Maybe you have to cut up your pizza, right? So think about them as deconstructed. Gourmet chefs do it all the time, right? You can still have your hamburger, just might need to be deconstructed. So stay proactive, keep doing your exercises, and move forward. Thank you.
Thank you, Sophia. That was wonderful and so very informative. We're going to move into questions now, and participants can submit their questions through the chat feature. There were a few questions submitted as Sophia was giving her presentation, so I'm going to start with those. Barbara asked about dairy food and ice cream and whether or not myth or fact that it increases phlegm and makes it easier to choke.
That's a good question. Scientifically, I'm going to be honest, I don't know, but yes, I've heard that it does increase phlegm. And I think if you have phlegm and you don't have that good strong cough, it's going to make it harder, right? So I think you have to listen to your body. If you're not able to manage, we call those secretions, right? Then you might have to be a little more careful.
Okay, bummer. We
I
all think about
know. It's
milkshakes and smoothies and that kind of thing as being easy to swallow. So,
right. So, I
and
mean, if it doesn't cause you phlegm, then that's a good news. But if it does, I mean, I think it's one of those depends on the person kind of thing.
well, it's good to
Juice
keep that
based,
in.
maybe juice based smoothies.
Juice based, yeah. Judy also had a question. She mentioned that many people throw their heads back to swallow, and she's heard that that's not good to do with PD. So like the old pill.
Um, well, I mean, okay, so I was saying we can't treat what we can't see. So that's something that we would test on a video swallow, right? If that's what the person does, then that's something we can do during the test to see if that's helping the person. Um, Again, a lot of times it's person to person. I know that's not a great answer, but it's the truth. So,
Well,
and I can actually look into that. I don't know specifically that it's bad for PD. So I can get back to them for those
yeah.
specifics.
Thank you. I think it is very, very individualized, and all of this information everybody has to kind of take it in and apply it to their personal situation. But having the knowledge is so very important. Brian put up a very interesting question here. He wanted to know, and I don't think I've even heard of this, has anyone been diagnosed with Zenker's diverticulum, and has anybody had surgery for that condition, and was it helpful?
That's to me,
Back to
to the
you.
group.
Yes.
Yeah. So Zankers is, it's like a little pocket that forms on the side of your esophagus. I mean, yeah, like in the pharynx. So it kind of shows up on a video swallow. It's like a little pocket. And I hate to say, I don't know anything about the surgery. Sorry. I
There
can, again,
anybody?
look it up.
Mhm.
Anybody else have had experience with Zankers?
Um, no, we're not getting any response on that, but it sounds kind of like almost a hernia where things get stuck, maybe.
Yeah, it's like a little pocket,
Mm-hmm.
but I've never heard of
Wow.
surgery for it.
Well, that would be interesting to find out. We
Hmm.
appreciate your research on that. Thank you.
Yes, I'm writing
Charles,
these down.
okay, and so am I. Charles had a question about, he wanted to know if you could spend a few minutes on potential exercises to help minimize drooling.
You want me to do that now? Spend some time
If
on
you,
that?
sure, sure, please.
Yeah, so that's going to be like your lip strength, right? So, what I tell my clients, my patients, if they are drooling, it's really trying to practice keeping that mouth closed. And so, okay, this is what I tell them. If you're drooling, keep your mouth closed and you have to swallow every once in a while because maybe your body is not sensing, right? And so, just kind of getting in the habit of just swallowing so that you don't drool. Um, there are exercises you can do like puckering, right? Doing the smile. Pucker smile is one of the exercises, um, off the top of my head. um, sucking on a lollipop, mm-hmm, because you're having to keep your mouth closed around the stick. So those are some you can do, but definitely making an effort to keep your mouth closed and then habitually swallowing, right? Because that reflex may not be there anymore, or it may be reduced. And then maybe even just kind of like swallowing hard.
So it sounds like there's a lot of just intentional cognitive components to this.
There is, right? Um,
Mm-hmm.
it's making conscious efforts. Yes, absolutely.
That's key for so much, I think. So, Barbara Paul had another question. Does the EMST device require a prescription?
It doesn't require a prescription, but I would recommend talking to a speech pathologist just to make sure you're getting it right. But it doesn't require a prescription.
Okay, and along that lines, Ava asks if using an EMST 150 for the prescribed time, can you stop and then be able to start using it again?
Yes, because it has a dial, you can then increase the pressure and then start again, right? And so that's what you would
Mhm.
do. There's also a light one. I think it's an EMST 75, where if the 150 is just too hard for someone. But basically, yeah, then once you have reached that one, you can try the next level and then do the program again.
So it's weightlifting for your lungs.
It really is. It really is.
Hmm.
That's what I
Hmm.
say.
Wow. Wow. Let's see. Bruce had a good question. Any crossover or overlap between sleep apnea and swallowing problems?
There is a correlation. Um, Again, I'd have to. These are great questions, and you're keeping me on my toes, and I feel so bad that I don't have them off the top of my head. Um, I
We're
do
giving you
know
homework.
you really are. That's good because I love to learn. I do know that sleep apnea or like a CPAP device is one of the ways that we help with. So we have the uvula in the back of our throat that actually works as a little flap to protect our nasal cavity from food going in. So I know that it's used for like that therapy is used to strengthen that uvula to keep food from going into the nasal cavity. But as far as like sleep apnea and swallowing and dysphagia, I'm not sure.
Thank you. And it's impossible to know everything, but knowing how to get that information is so valuable. So,
Yes, our
that's
field is very broad, but
yes.
I will get you answers. I promise. I feel bad.
Please don't feel bad. You're providing such amazing information, that's so very applicable. Barbara asks, how do you keep your cough?
How do you keep your cough? That's a great question. So
Hmm.
doing those expiratory muscle training, right? An EMST, that's a good way. And then even just like a volitional cough, right? Just coughing on purpose, doing your exercises. I know, Barbara, you're doing Speak Out. So keeping up with those exercises, anything that's going to keep you um, exhaling, right? Singing, the vocal exercises that you do, all of that's going to contribute to keeping a cough. And then EMST, I mean, there's such great evidence for that.
Thank you. Okay, I have a question. I brought this up before we started. We're all into our adult sippy cups and our thermoses, and are there dangers, risks associated? Somebody once told me that you shouldn't use straws with swallowing problems because it puts too much liquid at the back of the throat. What's your thought on all of these?
So that's a great question. So using a straw does move the liquid faster. And so your body has
Hmm.
to work even quicker, right, to coordinate and protect the airway. So during a swallow evaluation, that's one thing we do test is a straw. So if I'm noticing that you're coughing or choking using a straw, I might say no straws for you, right? But if you're managing using a straw and it's not causing you any issues, then use a straw, right? Yeah, but if you're showing those signs like, oh, I am like coughing when I use a straw, but when I take regular sips, I'm not coughing, then maybe the straw is just moving the water too fast for you. So that's part of an evaluation, right? That's something to
Mhm.
definitely bring up. When I do a video swallow, I do test straws as well.
Mhm.
Yeah. So if you're not
And
coughing or choking, then
at
you're
what
okay.
and at what point, speaking of liquids, would you recommend a thickening agent for liquids?
Yeah. So I wouldn't, like I said in the presentation, I wouldn't recommend thickening liquids unless you've had a video swallow.
Okay.
Okay. So there's evidence to show that a lot of people are more likely to silently aspirate a thickened liquid, right? So
Mhm.
meaning that it goes down the airway, but you don't sense it, you don't cough. It's heavier for the body to kick out with a cough, especially if your cough is not strong. And so it's going to be harder for the body to do that. So,
Mhm.
saying that, if I've done a video swallow and you're aspirating water, like regular water, it's just not working for you, I'm going to try a thickened liquid. I'm going to try the mildly thick, which is like syrup, or I'm going to try the honey thick liquid, and I'm going to see which one is better for you. If I see on the video that that is working for you and you're passing it and it's not going the wrong way, then I'm going to recommend a thickened liquid, but only after I've done a video swallow. There are speech therapists.
Mhm.
I mean, it's kind of a debate in our field. Some people will recommend it if they notice people are coughing on thin liquids. For me, I won't do it unless I do a video swallow. So just kind of it's a debate in our field, to be quite honest. So that's my recommendation. Once you've had it, also it can cause dehydration, right? People don't like it. It's not that great because people stop. It's like they don't want to drink it, and so you can become dehydrated. I will often
Mhm.
recommend ice chips if someone's on a thickened liquid. That way you can get that, you can wet your whistle, as they say. You can get a little hydration. Water doesn't necessarily cause a pneumonia. And usually the ice chip will melt and be absorbed by the body before it even hits the airway. So that's my way of, like, if you're on a thickened liquid, I still want you to have a little bit of regular water, right, to kind of help you stay hydrated.
That's very, very useful information. And I think that answers Barbara had a no, I'm sorry, Monica had a statement about the recent research discouraging the use of thickening liquids, which is quite interesting because I've seen a lot of hospice settings where they do use thickened liquids, and you know, I that they don't involve speech therapists. So, um, Barbara asked about consuming smoothies with a spoon. Is that a concern?
Nope, no concern. However, no, not at all. No, if you feel like, yeah. Again, if
Okay.
you're not showing any of those dysphagia signs and that's more comfortable for you, yeah, do it.
Okay, great. Thanks. Now, Thomas has a question. I wonder how important the various diagnostic tests are in the case where there's clearly significant dysphagia. Score 22. My dad has fairly advanced PD. And he goes on to say it's also very difficult to get him to do the exercises. So, what would your recommendation be in that kind of situation?
That's one of those situations where it becomes a family decision as to continue feeding the family member with a known aspiration risk to kind of keep, some quality of life. Or maybe it's time to make that decision for alternative nutrition, right?
Okay.
I think that's a lot of times I will recommend a video swallow just to see, just to see
Mhm.
what's happening so we can get information to make a better decision. Maybe there is, a thickened liquid that might help him, right? Or having pureed food. So I would recommend, yeah, doing a video swallow, getting information, and then making your decision based on that. So
Okay.
it becomes, yeah, it becomes that it's like a family decision. Like I can
Mm-hmm.
give you the
Mm-hmm.
information, but I can't make that decision for you.
Right, right. And that is very difficult because you do want to make sure that somebody is adequately nourished and but you don't want them to be at risk. So,
Right, right.
mhm.
So families, there are some families that opt to feed because he really likes X to eat or to drink, and there's others that opt for the, the feeding tube or other.
Okay, thanks. Judy has a question about are there any foods or fruits that are more difficult for swallowing?
Those crunchy fruits, right? Apples sometimes are hard, like they're juicy and solid. So it's going to be those hard foods that are a little bit harder for people. Um, that's one I can think of right now. Like apples are hard, right? So opt for
Mhm.
something softer. Cantaloupe can be hard depending on how you like it. So anything that's going to be harder, like a hard consistency, is going to be a little bit harder for someone with PD. Um, but again, if you can eat it without a problem, then eat it, right? Um, if you start to have those issues, then we need to modify it. I mean, that's my thinking. So you may have to have it a different way. Maybe you do, maybe it's an applesauce, or maybe there's like a midway, like in an apple pie where, apple is a little bit softer, right? So yeah, you're only going to avoid those foods if you're having issues with them.
Yeah. So if it ain't broke, we're not going to fix it.
Yes. Yeah.
Does temperature, Ava's got a question about the temperature of food, like soups, for instance. Does that matter?
It doesn't matter. There is um, a therapy that you use, like cold foods, to increase sensation, that some people use. It's called thermal tactile stimulation, but that's the only thing I know for like temperatures, right? But
Mhm.
also keep in mind, if you do have reduced sensation and maybe you're not feeling how hot it is, that can be an issue, right? So maybe
Right. Hmm.
testing it with, having someone else test it, but also that's a, an issue I can foresee, is just
Hmm.
that reduced sensation that you might burn your mouth.
Oh, that's a really good point.
Mm-hmm.
So, let's see. Sue asked, does anybody have problems, difficulty slurping foods like spaghetti, and are there any exercises that can help with that? It's a great question.
That is a great question. So that's again like that labial, right? Like the lips, right? So working on strengthening those. And I'll find some good exercises, but like I said, off the top of my head is like that pucker and smile to help those. But that's going to be a, a lingual. I'm trying to think what muscles we use to slurp. So the lips, tongue, and then
Hmm.
those muscles of inhalation, right? So it's kind of complicated. So I think we'd have to see like where that weakness is, right? So if we're thinking about it, like I curl up my tongue, I pucker my lips, and then I'm sucking. So it could be different depending on where that weakness is.
Okay.
Does that make sense? So it's kind of
It
hard
it
to
does. Hmm.
pinpoint, but you can, yeah. So
So many different pieces. It's just so
uh,
many moving
it's
parts.
it's so complicated, right? And we just think, oh, I'm just sucking, but no, it's involving the lips, the tongue, and that inhalation.
And Monica mentioned also the abdominal muscles a little bit. Wow.
Yeah, because that's,
So,
yeah, exactly.
mhm. Ava asked, she said there's a treatment where a TENS-like tool is used to identify or treat this, and are you familiar with it, and does it help?
I'm not sure what a TENS like tool
Like a
is.
neurostimulation?
Oh, yes. So there is, it's called, yeah, NMES. So it's neuromuscular electrical stimulation. So that they put electrodes. The evidence is a little bit mixed on that, because there's no standardization as to where people are placing the electrodes. There is some evidence to show that yes, it works, but again, the
Mm.
evidence is mixed because there's no standardization. So there's still, the research is kind of still out on that. But yes,
Very
some people
interesting.
do. Yeah, and you have to be trained to do it. To be honest, I don't think I know anyone who's trained to do those.
Mhm.
So again, research is mixed on that, but there is some evidence to indicate that it might work.
That's very interesting. Wow. And let's see, just to wind up, we've got one more comment here from um, Charles, that his experience is that drinking lukewarm liquids is easier than swallowing cold liquids. In fact, that's how he's able to get his pills down.
Hmm,
So
okay.
I think we need to wind down because we're already at 5 minutes after 12, but I just want to extend a huge thank you to Sophia. This has been a wonderful and very informative presentation. And thank you all for joining us today. We just so appreciate it. If you enjoyed today's program, we do invite you to visit PCLA.org and make your donation today. You can be part of the Finding the Joy fundraising campaign for 2025. Your support really does help us continue our mission to improve the lives of people and families in our community affected by Parkinson's disease. And for more information on that, you can refer to the contact details on the screen. Remember, PCLA is a nonprofit organization and all donations are tax deductible. Thank you for joining us in making a difference. And on November 5th, join us in person for our Lunch and Learn series, which will feature Dr. Jeff Bronstein, Director of Movement Disorders at the David Geffen School of Medicine at UCLA. A link to register for these events, as well as updates for all of our programs, will be sent out through email and on our PCLA website. Thanks, everyone, and have a wonderful day.